This video will consider the internal jugular approach to central venous catheterization. Internal jugular venous cannulation was previously associated with a higher rate of arterial puncture than the other main routes. However, the modern use of ultrasound may render older data obsolete. The right internal jugular vein provides a relatively straight route to the superior vena cava, allowing favourable conditions for renal replacement and temporary pacing wire insertion. The internal jugular route should be avoided in combative patients or those with neck injuries. The patient ideally should be able to lay still in a head-down position for the duration of the procedure. The patient is placed in a position of at least 15 degrees head down, with the head turned slightly away from the side of insertion. With the advent of ultrasound guidance, it is often possible to place the catheters even with the head midline. Anatomically, the internal jugular vein travels from its emergence from the skull base contained in the carotid sheath, along with the carotid artery and vagus nerve. The vein runs anterolaterally to the carotid artery in most people, and runs behind the sternocleidomastoid muscle, emerging between the sternal and clavicular heads at the base of the neck, running along the medial border of the latter. The vein joins the subclavian vein behind the clavicular head to form the brachiocephalic vein. The internal jugular vein on the left has a couple of important anatomical considerations of its own. It has a less direct route to the superior vena cava. It is usually smaller. It is associated with a higher pleural dome compared to the right side. Furthermore, the thoracic duct enters the venous circulation on the left side, usually in the region of the internal jugular or subclavian vein. On this side, therefore, it is possible to cause injury to the thoracic duct. The rest of this video will consider cannulation of the right internal jugular vein. The important surface landmarks to identify are the two heads of sternocleidomastoid, as already mentioned, and the carotid artery. If you draw two imaginary lines, one between the sternal notch and the mastoid process, and the other lateral from the thyroid cartilage, these two lines should intersect at the point of the carotid, as shown by the blue dashed lines in this picture. Asking the patient to flex their neck if appropriate should allow identification of the sternocleidomastoid heads, allowing further identification of the likely position of the internal jugular vein. Before ultrasound was routinely available, the blind approach relied on the hope that the internal jugular vein ran as expected, anterior and lateral to the artery, heading down the medial border of the clavicular head of the muscle. The use of ultrasound, however, has shown that this assumption is often flawed and that many variants exist. Ultrasound guidance has improved the speed, accuracy, and complication rate of internal jugular cannulation to the point where many units would consider ultrasound use as a standard of care. In the images shown, the left internal jugular is visualized as a larger, more compressible structure in comparison to the carotid artery, which in this image lies, as expected, anterior and lateral to the artery. The following are site-specific insertion tips for the internal jugular approach. Reassess the anatomy with ultrasound to establish the correct insertion point, and assess the approximate insertion depth as an added safety measure. Anaesthetize the area of skin both around the insertion site and the likely area of suture insertion. It is at this stage that the procedure of inserting the central line can occur. Once the correct insertion point has been identified, the needle is inserted at approximately 40 degrees to the skin under dynamic ultrasound monitoring. Advance the needle slowly taking care to visualize the tip rather than the shaft of the needle. This prevents inadvertent transfixing of the vessel and penetration of deeper structures. It is important to be aware of the approximate depth by which the vein should be encountered. Often, the needle tip will bounce off the vein wall. Simply apply gentle pressure. A subtle give is usually felt, with venous blood suddenly freely being aspirated. At this point, carefully put down the ultrasound probe while simultaneously securing the needle with usually your left hand, thus preventing it from slipping out of or through the vein. Assuming confirmed venous blood continues to be freely aspirated through the needle, the wire is threaded easily into the vessel. If the wire does not advance, withdraw the wire and ensure blood can still be easily withdrawn. If it does not, reapply the ultrasound probe to ensure the needle is still in the vessel and adjust as necessary. If the needle has come out of the vein, withdraw the needle, press on the site with gauze to prevent hematoma formation for 3 to 5 minutes, and repeat the attempt. Repeated failure to thread the wire despite these efforts should prompt you to seek assistance, as venous stenosis, thrombus, or another complication may be compromising the procedure. Assuming the wire has threaded easily and is in place, confirm placement on ultrasound prior to dilating. After dilating, ensure the central line is inserted to the desired depth prior to aspirating and flushing all lumens. For the right internal jugular vein, a rough guide should be 12 to 15 centimeters for an adult, and on the left 14 to 18 centimeters. Secure, cover, and document as previously described in the other videos. In summary, the internal jugular approach has the following advantages and limitations. Advantages include an increase in success and safety in the era of ultrasound. Limitations include the increased risk of carotid injury, air embolus, neck and chest structure injury and catheter malposition. There's also the infection risk in the context of excessive tracheostomy secretions or for prolonged cannulation. However, given this route is readily taught and safe in an emergency, it still retains a valuable place in our ICUs. The next video will focus on the femoral venous line insertion technique.